Welcome to the deep dive. This is where we take the information, you bring us your notes, your research, and we really dig in and try to make it clear, high yield, and just plain useful.
Exactly. Our job is to help you navigate the material, pick out what's really key, connect the dots, and hopefully make it stick, sort of cut through the noise.
And today we've got a very focused task. We're diving deep into puerperal pyrexia, that's fever after childbirth, using some great revision notes someone shared. The goal: turn these notes into a solid, easy-to-follow guide, perfect for revision.
Yeah, think of it like we're building that study guide together right now.
Yeah.
Pulling out the essentials, what it is, the causes, the risks, how you diagnose it, manage it, and importantly, what complications can arise. It's
Yeah.
all coming straight from these notes you sent.
Okay, brilliant. Let's jump right in then. Puerperal pyrexia. First things first, the definition. What's the core definition we need to nail down?
Right, so, okay, it literally means fever after birth, but the clinical definition in the notes is very precise, and this is really key for revision. It's defined as a body temperature of 38 degrees Celsius or higher.
Okay, 38 or higher.
Yeah, recorded on any 2 days within the first 10 days after the delivery. But, and this is a crucial exclusion, it doesn't count fevers in that very first 24-hour period postpartum.
Got it. So 38 or more on 2 separate days between day 2 and day 10 postpartum. Makes sense. And where does this fever usually originate? Where are the common sources?
The notes list the typical places you'd suspect an issue postpartum. Things like the pelvic organs themselves, the urinary tract, sometimes the respiratory tract, the breasts are a common one, any surgical wounds like from a C-section or maybe an episiotomy repair, and even the legs.
That's a good checklist of areas to consider. And you mentioned infection is a big part, but the note said it's not only infection causing the fever.
That's right. Infection is definitely the major player here, but the notes do explicitly mention that non-infectious factors can also cause, or at least contribute to, this kind of postpartum fever.
And just quickly, why is this topic so important? I saw some, well, quite stark numbers in the material provided.
Yeah, you did.
Yeah.
Globally, this is a huge issue. Puerperal sepsis, which often starts with this pyrexia, leads to a shocking number of maternal deaths worldwide. The notes mentioned around 75,000 deaths every year, mainly in lower-income settings.
Wow.
But crucially, the notes also point out it's still relevant even here in the UK. It remains a notable contributor to maternal mortality.
Yeah.
So it really highlights why understanding it is so vital.
Definitely puts it into perspective. Okay, so moving on from what it is and why it matters, let's talk causes. The etiology. You said infection is key, but what specific types are listed?
So the notes break it down into infectious and non-infectious causes. For infectious, we're talking common culprits like endometritis, that's infection of the uterine lining, very frequent. Urinary tract infections, UTIs, also really common, often caused by E. coli. Then there's mastitis, which is breast infection, often linked to staph species. And of course, wound infections, especially after a C-section, are a big one. The notes also mention genital tract infections more broadly, caused by various bacteria.
Right, so a range of potential bacterial infections driving it. What about the non-infectious side? What else could be causing a fever then?
Well, the non-infectious list includes things that can kind of mimic infection by causing a fever. Things like retained products of conception, basically, if some placental tissue gets left behind.
Oh, okay.
Venous thromboembolism, or VTE, like a blood clot, perhaps in the leg or pelvis, that can cause fever too. And atelectasis, that's like a partial lung collapse, can happen after surgery or being less mobile. That's another non-infectious cause listed.
And wasn't there one slightly more unusual one mentioned too?
Yeah, glandular fever was also listed as a possibility, though, in practice, you'd probably investigate the other causes first.
Okay, good to distinguish those. Now, a really important part for revision, I imagine. Who is actually more likely to get this? The risk factors. There was quite a detailed list.
Absolutely. This is super high yield. Knowing the risk factors helps you identify who needs closer monitoring. The notes give a pretty comprehensive list. Having a Caesarean section delivery, that's a major one, especially what they call a lower segment C-section or LSCS.
Right.
Prolonged labor, that definitely increases the risk. Premature rupture of membranes if the waters break early. Multiple vaginal examinations during labor is another factor, probably because it increases the chance of introducing bacteria.
Makes sense.
Poor perineal hygiene is listed too. And then there are patient factors.
Like existing conditions.
Exactly. These like diabetes, anemia, obesity, or any kind of immunosuppression make someone more vulnerable. Trauma during delivery is another one. Significant tears needing stitches or using instruments like forceps or a vacuum. And the notes kind of summarize the underlying mechanism. It's often an ascending infection. Bacteria that normally live in the vagina travel upwards. So anything that helps that happen or weakens the body's defenses there increases the risk.
That ties it all together really well. The risks are about introducing bugs or making it easier for them to take hold.
So speaking of how it happens, the pathophysiology, the how, can we just briefly touch on that?
Yeah, the basic mechanism described is pretty straightforward. Bacteria or sometimes other pathogens get introduced into the genital tract or maybe even the bloodstream. This happens during labor, the delivery itself, or maybe during postpartum procedures.
And those risk factors we just went through essentially provide the opening.
Precisely. They either make it easier for the microbes to get in, or they impair the woman's ability to fight them off. Once those pathogens get a foothold, they trigger inflammation. The body reacts, mounts an immune response, and it's this inflammation spreading that causes the fever and the other signs of infection we see. Got it. So, introduction, opportunity via risk factors, infection, inflammation, symptoms. Clear. Now, if someone does have a fever postpartum, is it always definitely puerperal pyrexia from one of these causes? The notes listed differential diagnosis, other things it might be.
Yeah, and this is so important for practice and for exams too. A postpartum fever doesn't automatically equal, say, endometritis. You have to think broader. What else could it be? The notes list other conditions that cause fever around this time that need ruling out.
Like what specifically?
Well, they relist urinary tract infections and wound infections, which could be anywhere, not just the C-section scar. Pneumonia is on the list. Thrombophlebitis, vein inflammation, often with a clot like VTE. And they bring back those non-infectious causes too, like atelectasis and retained products, the key differentials. So assessing someone with postpartum fever is really a process of elimination, using the clues.
Okay, that makes sense. Systematically working through the possibilities. What about how common this actually is? Did the notes mention any stats on incidence?
They did provide a specific figure for the UK. It said approximately 3% to 4% of postpartum women experience puerperal pyrexia.
3 to 4%.
Yeah, not insignificant.
Yeah.
But it also noted that the actual rate can vary, depending on the hospital setting, the patient population, probably reflecting differences in risk factors and prevention strategies.
Right, okay, 3 to 4%. So if a woman does develop this, what are the typical signs and symptoms? What does it look like, and how do you evaluate them?
So the clinical presentation is where you get your main clues. Obviously, the key sign is the fever 38 degrees C or higher. But women might also report chills, feeling generally unwell, that malaise we mentioned, or having abdominal pain.
And are there specific symptoms that point towards where the infection might be?
Yes, absolutely. And these are really helpful for narrowing it down. For instance, foul-smelling vaginal discharge, the lochia, is a big red flag for a uterine infection like endometritis. Painful urination, dysuria, that points very strongly towards a UTI. Breast tenderness, redness, swelling that suggests mastitis. And if there's a wound, then redness, heat, swelling, or drainage from that site clearly indicates a wound infection.
Right, so listening carefully to those specific complaints is key. And then how do you follow that up with a physical examination?
The notes lay out a systematic approach. First, a really thorough history, asking about things like, when did the membranes rupture? How long was the labor? Were forceps or vacuum used? Were stitches needed? Crucially, was the placenta thought to be complete? How much bleeding was there? You're basically probing all those risk factors and potential sources we talked about. Then the physical exam. Vitals, first temperature, obviously, but also pulse rate, are they tachycardic? Respiratory rate, is it elevated? Then physically examine potential sources. Palpate the uterus, check its size. Is it tender? Is it boggy? Look at the perineum. Any wounds? Check the lochi's appearance and smell. Examine the breasts. Listen to the chest for lung sounds. Check the abdomen for tenderness or guarding. And don't forget the legs. Check for signs of a DVT, like swelling or calf tenderness. It's about systematically checking those hot spots.
Okay, so history raises suspicion, exam finds the physical signs, and then you need investigations to confirm things.
Exactly. Investigations aim to pinpoint the source of the fever and, if it is infection, identify the specific bug causing it. The notes rightly stress that investigation should be guided by the clinical findings. You don't just order everything on everyone.
What kind of tests are usually involved?
Well, blood tests are pretty standard. You're looking for signs of inflammation or infection, so things like C-reactive protein, CRP, and the white blood cell count, WBC, are key markers. A full blood count, FBC, gives the overall picture. Then, critically important, are culture samples from suspected sites.
Like swabs?
Yeah, high vaginal swabs are very common. Urine cultures, too. You might need swabs from wounds, maybe even the throat, depending on symptoms. And blood cultures are vital if you suspect the infection might have spread into the bloodstream, sepsis. Getting those cultures helps identify the bacteria and choose the right antibiotics.
What about imaging?
An ultrasound scan is mentioned, mostly used to look for retained products in the uterus, or maybe a collection of pus, like a pelvic abscess. A chest X-ray, or maybe a sputum culture would be considered if you suspect a respiratory source, like pneumonia.
Right, targeted investigations based on the picture. Okay, we've covered what it is, the causes, risks, symptoms, and tests. Now, the really practical bit, management. How do the notes say puerperal pyrexia should be treated?
Management has a few layers. There's general supportive care, then specific medical treatments, and sometimes even surgery.
Let's start with the general measures. What's involved there?
Pretty basic but important stuff. Making sure the woman gets enough rest, stays well hydrated, that's particularly important if she's breastfeeding. Simple things like ice packs can help with local pain, like from a perineal tear or mastitis. There was also a note about in very specific circumstances like suspected group A strep or meningococcus, considering preventative antibiotics, prophylaxis for close family members, but that's quite rare.
Okay, and when does it tip over into being an emergency? There was that list of urgent referral signs.
Yes, this list is absolutely critical. These are the red flags that scream potential sepsis or severe illness, needing immediate action. The notes list them explicitly. The fever itself, 38 degrees C, yes, the definition. But persistent high fever is a warning. Sustained tachycardia, heart rate staying high, like 90 beats per minute or more. A fast respiratory rate, 20 breaths per minute or more. Concerning abdominal or chest pain. Diarrhea or vomiting, which can be signs of systemic upset. Significant pain or tenderness over the uterus, or kind of in the back where the kidneys are, the renal angle, and just any sign that the patient seems severely unwell or distressed.
Right, those definitely sound like signs the infection is escalating. So that logically leads to medical treatment, primarily antibiotics, I guess.
Absolutely. Antibiotics are the cornerstone, especially if infection is the cause. And the notes really stress the urgency. If you suspect severe sepsis, the goal is intravenous broad-spectrum antibiotics within 1 hour. Time is critical.
Wow, within an hour. Are there specific examples of antibiotics mentioned?
Yes, they suggest broad-spectrum options like piperacillin with tazobactam, or maybe a carbapenem antibiotic, often plus clindamycin, to cover different types of bacteria, including anaerobes. When choosing, you have to think about things like breastfeeding safety and whether the patient might have MRSA. Oh, and an interesting point for revision, the notes mention avoiding NSAIDs, like ibuprofen, if you suspect group A strep infection. Apparently, they might hinder the body's fight against that specific bug.
Good tip. Any other medical treatments mentioned?
Intravenous immunoglobulin, IVI, that's like concentrated antibodies, is listed as an option for really severe strep or staph infections. And if the fever is prolonged and investigations point towards a blood clot, a VTE, then heparin treatment would be started.
Okay, so antibiotics are key, tailored based on suspicion and severity. What about surgery? When might that be necessary?
Surgery comes into play mainly if investigations show an abscess has formed that collection of pus. The notes are clear. The fever and infection probably won't resolve properly until that abscess is drained, usually via a surgical procedure called incision and drainage.
Right. And looking upstream, are there ways to prevent this happening in the first place? Preventative measures.
Yeah, the notes list quite a few, mostly common sense measures around hygiene and prompt care. Things like maintaining good hygiene during labor and any exams. Treating any existing infections promptly. Using preventative prophylactic antibiotics during long labors or routinely for C-sections is recommended.
Okay.
Minimizing how often urinary catheters are used helps reduce UTI risk. Cleaning and stitching up any tears or wounds quickly is important. Making sure the whole placenta came out and keeping track of blood loss helps spot problems early. And encouraging women to get moving soon after birth and supporting breastfeeding are also listed as helpful preventative steps.
That's a good range of actions. So
Yeah.
putting it all together, what's the usual outcome? The prognosis for someone who gets puerperal pyrexia.
Generally, the prognosis is good, but that's with the big caveat of early recognition and the right treatment starting quickly. Prompt management is key to preventing complications. But, the ultimate outcome really depends on what the underlying cause was. Some are inherently more serious, and whether any complications develop along the way.
Which brings us neatly to complications. If things do go wrong, what are the serious potential outcomes listed in the notes?
This is where it can get really serious, even life-threatening. The biggest worry is sepsis, that overwhelming body response to infection that can lead to organ failure.
Right.
Other complications include the infection spreading locally, like endometritis turning into a pelvic abscess. Wound infections can sometimes lead to the wound splitting open. It's called dehiscence. Deep vein thrombosis, DVT, is another potential complication, or sometimes the cause of the fever itself. And interestingly, postpartum depression is also listed as a potential complication, which highlights the toll a severe physical illness can take psychologically.
And those sepsis stats you mentioned right at the start are pretty sobering when you think about mortality risk.
They really are. The notes state sepsis with organ dysfunction carries a mortality rate of like 20–40%. If it progresses to septic shock where blood pressure plummets, that mortality rate tragically jumps up towards 60%.
Gosh.
The notes also detail other potential long-term issues if infections aren't treated properly. Genital tract infections could lead to infertility, internal scarring or adhesions, widespread infection in the abdomen called peritonitis, or even severe bleeding. Untreated UTIs might cause kidney infections, pyelonephritis, and potentially long-term kidney damage. And untreated mastitis can lead to a breast abscess.
Those potential complications really drive home why spotting this early and managing it properly is so incredibly important. It's definitely not just about treating a fever.
Exactly right. Understanding the signs, the risk factors, and the absolute necessity of quick investigation and management, it's not just exam knowledge, is it? It's fundamental for safe maternal care. Hopefully this deep dive using your notes helps build that solid framework.
Well, I think we've really taken those revision notes apart and hopefully put them back together in a way that makes sense. We've covered all the key areas of puerperal pyrexia definition, causes, risks, presentation, investigation, management, and those crucial complications. We hope breaking it down section by section helps it all sink in.
Yeah, thinking about those different parts, the causes, the risk factors list, those urgent red flag signs, the investigation pathway, hopefully framing it like that helps structure your revision and recall of this really important topic.
Thank you again for sharing the source material with us and for, well, joining us on this deep dive. And just a reminder, for more helpful revision resources, do check out pastthemsra.com.
And don't forget, freemsra.com also has free materials available.
Okay, as we finish up, here's something to think about, building on what we've discussed. We talked about lots of potential symptoms, but given how many things could cause that postpartum fever and how vital it is to pinpoint the source quickly, which single symptom mentioned in your notes do you think is perhaps the most specific pointer towards a uterine infection like endometritis, and why is nailing down that particular source so critical for deciding on management? Something to chew on.